Hello, this is Sandy Nadelson. This is week 11 of the research course, and I believe this one is the last video audio I'll be making. I thought it was last week, but then I found two more. Surprise! So anyway, this evidence-based practice guidelines PowerPoint is similar to the other evidence-based practice for this week's week 11's information. So nothing's going to be real shocking or eye-opening here, but it is interesting. There's a couple of case studies that are helpful. So the learning outcomes is to classify research questions into four categories: therapy, diagnosis, prognosis, etiology, causation / harm. Interpret research findings for strength and evidence in practice. Describe how research studies contribute to evidence-based practice guidelines. Explore sources of evidence-based practice guidelines, and describe schemas for grading EBP guidelines, and then cite resources in APA. So develop the question. You want to base it on your experience and think about this semester and what's been going on, and then write a question about the clinical issue that's been puzzling you. There are four main ways to classify research questions in terms of evidence-based therapy or evidence-based practice. First of all is therapy. What is the best therapy for this or that, and is this one better than that one? You'll see a couple of different questions related to therapy and formats for questions. The next one is diagnoses. So how best to diagnose maybe a urinary tract infection, maybe pregnancy, maybe cystic fibrosis. How's that? Another question is what is the prognosis? So with this treatment, what's the likelihood of this patient surviving or getting better or doing whatever? Etiology, causation, and harm. So what causes it? How can we help? That is another way that nurses look at evidence-based practice and develop questions related to evidence-based practice. As you're looking at research findings and their strength of that in terms of evidence-based practice, you can learn new research terms. How exciting! Continuous variables. And this is outcomes variables that change by degree. Example, pain, distress, blood pressure, weight. You can go pretty much from all of those 0 to the maximum of 10, for example, with pain. Discrete variables. Those are outcomes that occur or don't occur. It's either they're alive or they're dead. They have diarrhea or not. I like how diarrhea is in there twice. I guess someone must have really thought it's important to think about diarrhea. Confidence intervals. That's another one. Relative benefit increase. Number needed to treat. These are some acronyms that you may see. I think if you do take a look at them, I don't think we have time or energy to go over those here on this video, but those are numbers that you may see as you read research articles and findings. Another one that's a little easier to find and more relative and more likely to remember is sensitivity, and that is proportion of those with the disease who test positive. You could also, there's other definitions of course for sensitivity, but for research and evidence-based practice that's often what you'll see. Specificity, and that's the proportion of those without a disease who test negative. So if you're giving a test maybe for TB, maybe one of the time tests, how many people are testing positive and they really are versus how many will test positive and they're not. So that's sensitivity and specificity. And likelihood ratio is another one that you might see. So looking at a case study of evidence-based practice, so a nurse is wondering, what should we do in terms of helping patients or not who have type 2 diabetes? And the RN's working in primary care, and she sees that she's got quite a few patients who are having a hard time keeping their hemoglobin A1Cs under 7%. So it takes a look back at some research and founds a study that looks at that, and the study was about 24 family practice groups in Minnesota. So they had a lot of patients, over 8,000 patients between the ages of 18 and 89 in the study. It was a randomized controlled trial, which is, remember, one of the highest, or the highest level, the most rigorous type of study. And then they translated the intervention. In other words, they found some research and did some research and then said, this is how you can use it. And the control was usual clinical care. So a variety of people were studied. Some of them were put in a study group, some of them were not. So some of them just got the usual everyday stuff and some of them got special treatment. So of those who got the special treatment, the intervention group, 49% of them were able to keep their A1Cs below 7%. While those who were in the control who didn't get the special treatment, 44%. So you can see that there is a 5% difference between those with the intervention and those that are without. So obviously the intervention did something, but whether it was worth it or not is the big question. So with that, what's the patient population? What was the intervention? Was there control, and what was the outcome? In terms of outcome, the outcome of the study was that some of the patients were able to do better. And in terms of a continuous or discrete variable, continuous, A1C goes from 0 to, I'm not even sure, it depends on probably the machine how high it can go. And in this study, though, they found that there were quite a few patients who needed to get the special treatment for only a few that were actually benefited. So as a result, it did help, but is it really feasible to put all those patients through special intervention to have just pretty much one helped in the study? So here's another test looking at urinary tract infections and incontinence in nursing home patients. What they were doing is comparing how to diagnose, so this is a diagnostic one, a UTI. Some of them they just dipstick the wet incontinence pad, and other ones they sent to sample to the lab. Out of the patients, 19 of 27 who had UTIs were detected by dipstick. So about, it says 70%. I guess that seems a little high. 70% of them actually showed that it was sensitive. And now with the ones that had the urinary, so 69 of the patients without UTIs were accurately detected by the dipstick method. While, let me read that first one. 19 of 27 with UTIs were detected by the dipstick method. Okay, and 69 of the 71 without UTIs were, okay. Additional calculations involve the likelihood ratio. The likelihood ratio tells us how well a test distinguishes between patients who do and do not have a disorder. So a large positive LR is a high degree of certainty that patient has the disorder. A large negative LR, high degree of certainty that patient does not have the disorder. So basically what that says is, does it make sense to have patients have a dipstick or to send for the sample to the lab? Well, you have to kind of also take a look at some things that aren't brought up here. What's the cost, and what's the discomfort to the patient to get that sample? Maybe the dipstick can be used as a screening and then move on from there. So one needs to take their clinical knowledge and think about costs, think about patients, patient outcomes, patient satisfaction, patient discomfort, and then risks too. What if they don't get diagnosed with the UTI and they have one? What could happen? Is it worth that risk by doing this other dipstick test? So those are some things to consider. So how do research studies contribute to evidence-based practice guidelines? First, studies need to be written, presented, and published. So work needs to be done. And then, of course, people need to read them. They can be used with others to create a meta-analysis. They may be integrated in review. They may be published in things like the Cochrane's database and the Worldviews on Evidence-Based Nursing or Professional Journals are all sources. How are evidence-based practice guidelines developed? Well, first, like we mentioned in the last video, teams of clinical experts review the research literature and write guidelines using their clinical practice and other information. Teams can come from professional organizations, educational institutes, healthcare institutions. But once again, like I said, These are for big evidence-based practice guidelines and things that are going to be written and published and put on the internet. Not everything that's evidence-based practice has to be that complicated. There are many, many research evidence-based practice projects that happen just on a hospital floor. They're not going to be published, widely, but they can still improve patient care. There are some different organizations, once again, that help sponsor that. The Agency for Healthcare Research and Quality is one of the biggest ones, but other organizations also help. As you look at evidence-based practice guidelines, you want to take a look at how strong were the information they're pulling from, and what are they saying? Do they have a strong recommendation, a weak recommendation? And in terms of grading the work groups and finding out, do you really trust these people? Because it does take some trust. The U.S. Preventative Services Task Force, what kind of level of certainties regarded in terms of the benefit? And they do actually grade the recommendation. So, you really should do this A or I, insufficient evidence, or somewhere in between. So is it worth making that change? In terms of citing evidence-based practice, it depends on where you find. There are many different sources, journal articles, book chapters, scientific reports, and you want to report according to the source. So for a technical and research report, you might have the top one, author, and then the year, and then title of the report and the number. An example of this is, here's one about managing asthma in schools, and you can see here the publication in 2003. It's getting a little old, but it's not ancient, so it would be something worth taking a look at. And that is it for this last video. Take care. Bye now.